Well, I'd like to thank Ashley and the Sharp End Podcast for having me on today. This is the fourth in the mini medical series on the podcast from Norway. We've covered traumatic brain injuries, cervical spine injuries, chest trauma, and today we're going to talk about knee injuries. So knee injuries may or may not be just as serious as the other topics we have covered, but certainly we want to learn how to evaluate them. My name is Petitt. I'm a physician assistant and a member of a search and rescue team in Colorado. So today we're going to look at the basic anatomy of the knee. We have the thigh bone is the femur. We have the lower leg bone is the tibia, which bears most of the weight. And then we have the smaller bone on the side, the fibula, which is mostly for muscle attachments. We have the quadricep muscle group coming down, inserting onto the kneecap. This is called the quadricep tendon. We have our patella underneath the musculature here. And then we have the patella tendon attaching the patella to the tibia. Some people call that the patella ligament because it's technically connecting a bone, the patella, to another bone, the tibia. So with all of these anatomical parts, we can certainly cause a variety of injuries. Most of you have probably heard of an anterior cruciate ligament or an ACL tear. That is on the inside part of the knee, and it actually crisscrosses with the PCL or posterior cruciate ligament. That is a fairly common injury. Sometimes that is associated with an injury to the medial collateral ligament, which is on the inside part of the knee, and the medial meniscus, which is a C-shaped cartilage in the middle of the knee. That is called the terrible triad. Sometimes we can just have an isolated medial collateral ligament injury, and that occurs by having force hitting the outside part of the knee, straining the ligament on the inside part of the knee. The ACL is typically not a contact injury. It's typically associated with rotational forces or pivoting. The meniscus cartilage, which is a C-shaped cartilage on the inside and the outside part of the knee, which provides shock absorption, is also torn typically with rotational pivoting type injuries. Now, sometimes we have degenerative meniscus tears, which occurs as we get older, and simply walking on a trail can cause that problem. The quadricep comes down to the quadricep tendon here, and if we have a fall or a jump from a rock and landing with the knee bent, you can tear the quadricep tendon or the patella tendon. The problem with that is now you have a gap between the femur and the tibia, which is not connected, and therefore you would not be able to extend your leg, and that makes self-evacuation very dangerous. Another injury is certainly a patella dislocation. We see that commonly in young females where the kneecap slides off to the side, sometimes slides back in, other times stays dislocated. Now, you can put some pressure from the outside to the inside and some force while straightening the knee and reduce this, but that takes medical training. Of course, like in other podcasts, if you have not had wilderness first aid, wilderness first responder, or even beyond that, that is not a maneuver you would want to do. Fractures certainly can be common depending on the amount of energy involved with the injury. If you land right on your kneecap, you can certainly fracture your patella, and that creates the same problem as the patella tendon or quad tendon injury. There is now a gap and you cannot extend your knee. Certainly enough force can break the femur or break the tibia. A femur fracture is associated with a lot of blood loss and can be fairly significant, and often that is an injury that gets flown out by a medical helicopter. Now, not all injuries are that significant. I want to spend a minute talking about arthritis. And that seems like an odd topic, but if someone has some moderate arthritis and they're doing a new activity that they're not used to doing, that can certainly flare up and be very painful. And your primary and secondary exam hopefully can determine that based on listening to the subject's history. So there's lots of injuries that look similar, and I don't expect you to be able to tell the difference between them, but with training, you actually can. Now, with the head injury, we talked about prevention and wearing a helmet. The other ones, there really wasn't any preventative measures that we could see. With the knee, there is preventative measures. Fitness is very important. Don't do a hike or do a ski run or a climb that is above your ability or above your fitness level. It can lead to further injuries. 2 hiking sticks can make a big difference. It prevents small falls in a scree field or other slick environment. I can tell you from a search and rescue perspective, it is uncommon that we rescue somebody with a moderate-sized backpack and 2 ski poles or 2 hiking poles because they are prepared for most things. Certainly footwear matters, and being prepared. Now, scene safety. I should have mentioned this more in the previous podcast, but that always comes before you evaluate a subject. Is the scene safe? Are you below rockfall or an avalanche? Are you next to the edge of a cliff? Could there be an animal or a human factor that could be risky? Now keep in mind, if these are present, you do not have to treat that subject. It is better to have one subject than two. Even if you're concerned about serious injuries, if you see rock coming down a cliff, you can grab that subject and slide them out even prior to evaluating them, because if you left them where they were, they would certainly not have as good of an outcome. So prevention does work in the knee evaluation. Now, start with your primary and your secondary exam. The primary exam is ruling out life threats, any difficulties with breathing, any difficulties with circulation, and keeping the subject warm. So address those first. Now, in the previous podcast, we would automatically call search and rescue here, but this depends with a knee injury. If there's an obvious trauma to the femur or the tibia, there's a big deformity, an open wound, if the subject cannot move or feel their leg, yes, that's an immediate call for search and rescue. However, if they're just having some pain, it may be reasonable to complete a secondary exam. And by that, you're always going to compare to the opposite side, both how it feels and how it looks, looking for deformity, swelling, and then you're going to start your exam away from the injury. If you start pushing directly on the area that it's sore, that is going to cause the subject not to trust you and expecting each area to be painful. Therefore, I would always start away and work your way to the middle. The term we use in search and rescue, on our team at least when I teach this, is be firm, not creepy. You have to actually push on the bones and push on the ligaments to decide if there is an injury. You can't just barely touch them. So now you've completed your primary and secondary exam. Maybe that subject had some Tylenol or ibuprofen. You can certainly give that to them and see how they're doing. At any point, you can certainly call search and rescue. However, it takes some time for us to come to you. We have to get from our house to the trailhead and then hike up to you. Splinting is a great thing you can do for either deformities or to try to have somebody be more mobile. If you think about a femur fracture, you can always use tape or webbing or an A-strap, and you can tie it to the other leg. That provides excellent stability. If you're talking about a tibia fracture, you can use a SAM splint. And I have one here, and these are moldable and can be used with almost any type of injury. So you can fold this into two layers and put one on the outside and one on the inside and wrap it with your A-strap, and this can provide some stability to the knee. What we're trying to determine in our exam is, can they put weight on the knee and should they put weight on the knee? And that can sometimes be difficult to tell. But splinting can decrease swelling, can increase confidence, can decrease pain, and can certainly assist a rescue team if when they arrive, the area is already splinted. Certainly psychological first aid always plays a role in talking to your subject. So in synopsis, knee injuries can look like lots of other injuries. Always carry your 10 essentials. And as part of your 10 essentials, you always want to have an individual first aid kit. My recommendations in that is an A-strap and a SAM splint, multiple gloves and gauze pads. It takes more gauze than you think, so make sure you're carrying 10 or so pieces of gauze. I always recommend 2 pairs of gloves. You can always take one off, reach into your bag, not get blood on all of your clothing, and get what you need, then put the glove back on and treat the subject. The other thing is, if you've ever tried to put a medical glove back on your hand after it's been sweating, it's very difficult to get that glove back on. I also recommend individual medications. Carry what works for you, Tylenol, ibuprofen, those type of things, and a tourniquet. A tourniquet is one of the few things in the backcountry world that can actually save a life. And make sure you know how to use it and make sure you practice with it. I do recommend practice with a different one than you're actually caring to use for the real thing. So always tell somebody what you're going to do, where you're going to do it, and when you're going to be home. Carry your 10 essentials. Call search and rescue early. I hope you've enjoyed this mini-series on 4 different types of injuries. My name is Petitt. I look forward to talking to you again. And thank you for listening to the Sharp End Podcast. Stay safe.